Circumferential wiring is an effective procedure for stabilizing segments of loose teeth. Since this patient wants to retain some of these anterior teeth, it is necessary to stabilize the entire segment prior to initiating any periodontal therapy. Preoperative radiographs show resorption of the alveolar process around the remaining 6 mandibular teeth. Bone loss on the central incisors extends to the apices, and periapical lesions are present. A circumferential groove is cut on the labial and lingual aspects of all remaining teeth. The central incisors will be removed because of the extensive loss of their supporting and alveolar bone. The crowns can remain in the splint, but their roots must be sectioned from the upper half of the teeth and removed. The sockets are then allowed to heal, and the natural crown of the tooth becomes the pontic. A 10,000th inch diameter, non-resilient, soft wire is placed around the last tooth at one end of the segment. It is then carried into the labial groove and twisted around the last tooth on the other end of the segment. The wire is passed interdentally from the lingual to the labial surface under the master wire and carried over the master wire back through the lingual aspect. This is below the level of tooth contact. It is now brought from the lingual aspect between the right central and lateral incisors back to the labial, again passing it under the master wire and carrying it over the master wire to the lingual side. The process is repeated with the other teeth until the end tooth is again reached. This method of stabilization immobilizes the entire segment of teeth and is not aesthetically undesirable because the wire is ultimately covered with a plastic material. This plastic not only helps to stabilize the teeth and improve the aesthetics, but it also prevents any irritation to the lip, tongue, or mucosal surfaces. After the wire is passed through the embrasure to the lingual aspect of the canine tooth, it is wrapped around the distal surface of the tooth, and the two ends are twisted together. The grooves keep the wire in position. The extra length of wire is cut off and tucked in the interdental space. Prior to covering the area with plastic, wooden wedge-shaped called stimulants are placed between the teeth. They keep acrylic from obliterating the interdental space and ensure adequate embrasures for the patient's practice of good oral hygiene. Using a brush-on technique, the plastic is carried over the wires interdentally and allowed to flow labially and lingually. This eliminates the usual problem of loosening, which may occur when extracoronal stainless steel wire ligature is used for immobilization. Loosening, however, will not occur with this type of circumferential intracoronal splint. The stabilized teeth will permit periodontal therapy to be carried out on the canines and lateral incisors. These teeth can then be permanently immobilized and a mandibular removable partial denture fabricated. The lingual grooves are also filled with plastic using the same brush-on technique. After the plastic has polymerized, the excess is removed. Reduction is accomplished with finishing stones until the plastic is flush with the tooth surface. A tapered diamond point is used in this case. A rubber pumice wheel further refines and polishes the plastic. When mobility is tested, it is obvious that the teeth are stable. The patient can eat comfortably and still practice good oral hygiene. This stabilization permits periodontal therapy to be initiated prior to the fabrication of a partial denture. At this time, it is desirable to reduce the overall length of the clinical crowns of these mandibular teeth. This is easily accomplished because sufficient natural pulpal recession has occurred. The reduction also reduces torque on the entire splint and improves the general aesthetics. The pumice wheel is again used to smooth the cut incisal surfaces. These teeth are now able to serve as temporary abutments for a transitional or temporary removable prosthesis. In the meantime, the patient is made more comfortable when chewing. This type of temporary stabilization should not be utilized unless a definite restorative commitment has been received from the patient. These intracoronal splints should not be left in position for more than 6 months without careful checking for the occurrence of caries. Postoperative radiographs show the condition of these teeth immediately after stabilization. The roots of the periapically involved central incisors will now be removed. Topical anesthetic is applied. Infiltration anesthesia of these teeth is obtained. The crowns of the two central incisors are separated from their roots with a fine tapered stone. These roots are carefully removed from the labial aspect, while the crowns remain in the splints. There is enough alveolar support remaining around the lateral incisors and canines to use these teeth for prosthetic abutments. By employing this technique, it is not necessary for the patient to wear a removable partial denture during the surgical elimination of the periodontal pockets.